Hello and welcome to the ASCO Daily News Podcast. I'm Dr. James Stuart Ferriss, your guest host of the ASCO Daily News Podcast today. I'm an associate professor of gynecology and obstetrics and the Gynecologic Oncology Fellowship Program Director at Johns Hopkins Medicine. On today's episode, we'll be discussing the use of immunotherapy in cervical and endometrial cancers to advance the treatment of these malignancies. I'm delighted to be joined by two acclaimed experts in this space, Drs. Duska and Jaya Lea. Dr. Duska is professor of obstetrics and gynecology and serves as the associate dean for clinical research at the University of Virginia School of Medicine. Dr. Lea is professor of obstetrics and gynecology and chief of gynecologic oncology at the University of Texas Southwestern Medical Center. Our full disclosures are available in the transcript of this episode, and disclosures related to all episodes of the podcast are available at asco.org/dnpod. Drs. Duska and Lea, it's great to have you on the podcast today.
Thanks, Dr. Ferriss.
Thanks, Dr. Ferriss.
So let's get started. In recent years, we've had a revolution in the treatment of advanced endometrial and cervical cancers with improved outcomes for patients treated with immunotherapy. And when we say immunotherapy, we're specifically talking about immune checkpoint inhibitors today. A few of these agents have actually been approved in the United States for management of these diseases. In our discussion, I'd like to review the promise and challenges of targeting the immune system in patients with advanced endometrial and cervical cancers, as well as review the most recent evidence we have in these spaces. So let's start with cervix. We've had a lot of improvements in outcomes here, Dr. Lea, and with cervical cancer, we've seen improved overall survival with the incorporation of immunotherapy along with chemotherapy and anti-angiogenic therapy for advanced and recurrent disease. Can you remind us why cervical cancer is a good target for immunotherapy?
Yes, Dr. Ferriss. So immunotherapy for cervical cancer is supported by several molecular factors. And I think first and foremost, it's so important to remember that the majority of cervical cancers are HPV positive. And HPV positive cancers can induce a high level of inflammation. But this high level of inflammation actually contributes to evasion of immune surveillance. But what it also does is that it's responsible for the induction of PD-L1. And we've seen several studies that have shown that cervical cancers express PD-L1 anywhere from 50 to 90% of cases. Other pertinent factors I think to consider are that cervical cancer can be considered a tumor with a high tumor mutational burden. So the number of somatic mutations that we see in the DNA can be considered as a proxy for neoantigens. And so the higher the level of neoantigens, the more immunogenic the tumor. And then lastly, about 1 in 10 of cervical cancers present with microsatellite instability, which is an already established predictive biomarker for the response to immunotherapy.
So thinking about targeting PD-L1, what clinical evidence do we have that supports the use of immune checkpoint inhibitors in recurrent cervical cancer?
Yeah, so we now have several studies that have shown a benefit for immune checkpoint inhibitors. For example, Keynote 158 was a phase 2 basket study that investigated the anti-tumor activity of pembrolizumab, which is a PD-1 inhibitor in multiple cancer types, and specifically for patients with previously treated advanced cervical cancer. We were able to see an overall response rate of about 15% in those patients who had PD-L1 positive tumors. And then similarly, the EMPOWER-1 study, which was a phase 3 randomized trial that investigated the efficacy of cemiplimab, which is another one inhibitor, versus investigator choice of single-agent chemotherapy, showed a significant difference in median overall survival and progression-free survival in the cemiplimab group. There are several other studies that have investigated the efficacy of PD-1 or PD-L1 inhibitors in cervical cancer. And one specific PD-L1 inhibitor is nivolumab in CheckMate 358. Nivolumab was associated with an overall response rate of 26% in women who had previously treated cervical cancer.
Dr. Duska, do you have any thoughts?
I'm really interested in PD-L1 as a biomarker because in the A18 study, which we're going to get to, 95% of patients were PD-L1 positive by CPS, which is the scoring system that we use in cervix cancer. And some of the studies that you already mentioned, including BEAT-CC, which we're also going to talk about, reported results that were PD-L1 wasn't even considered. And so it begs the question, since PD-L1 is actually, when you look, again, depending on when in the course of disease you look at it, but more recent studies suggest 95% of cervical cancers express PD-L1, and agnostic is the word I was looking for. It seems, at least in BEAT-CC and similar trials, that PD-L1 is agnostic. I wonder if PD-L1 is really a good biomarker for response to checkpoint inhibitor therapy. And I wonder what your thoughts about that.
I think that's an excellent question. And to your point, that's correct. We saw in A18 that more than 90% of the patients had PD-L1 positivity, and the result was sort of generalizable to all comers. I think that's still, a matter of debate as to do we really PD-L1 as a biomarker in order to be able to incorporate checkpoint inhibitors treatment of patients.
So let's talk about the use of immune checkpoint inhibitors in the frontline setting. Until recently, we've not seen much improvement in overall survival since the introduction of anti-angiogenic therapy to the chemotherapy backbone, and that was in GOG 240. Let's talk about the changes that have recently occurred in this space.
So we've had some just very exciting data, specifically from initially Keynote 826 in its primary metastatic or first-line salvage setting. So Keynote 826, which was a phase 3 randomized controlled trial, was very practice-changing for us because it showed that incorporation of pembrolizumab to the first-line treatment of patients with metastatic or recurrent cervical cancer really changed the landscape for treatment in this group of patients. So keep in mind that prior to this study, the standard of care was carboplatin or cisplatin with paclitaxel plus or minus bevacizumab, which yielded a median overall survival ranging anywhere from 13 to 17 months, depending on whether you used bevacizumab or not. And then adding pembrolizumab to that regimen increased the median overall survival to 24 months, which is very promising.
If I remember correctly, 826 allowed investigator choice use of bevacizumab. And initially, we were unsure about which regimen was best. Has there been additional data since?
There has been additional data since. And another study that was done in the same vein was the BEAT-CC trial, which also looked at a different checkpoint inhibitor, atezolizumab in combination now with bevacizumab and platinum-based chemotherapy. And the control arm for this study was the GOG 240 regimen, which included the bevacizumab. And this study showed both the progression-free and overall survival difference. The median overall survival in this study was 32 months with the incorporation of the checkpoint inhibitor to the bevacizumab and platinum-based chemotherapy. So the way that I look at it is that the BEAT-CC trial basically confirmed the findings of Keynote 826 and highlights that it is important for us to incorporate checkpoint inhibition or immunotherapy along with bevacizumab when we're treating patients with recurrent. So,
also, folks with primary advanced treatment for cervical cancer, this would be a great regimen. Is that right?
Absolutely. Primary advanced, we would want to use the same regimen for that.
Okay. What about locally advanced in primary treatment? What advances have we seen?
So we've had some major changes in that field as well, especially with the recent Keynote A18 data, where pembrolizumab was administered in combination with external beam radiation and concurrent chemotherapy. And this study showed that there was significant and clinically meaningful improvement in progression-free survival compared to chemoradiation alone. Specifically, the progression-free survival at 24 months using pembrolizumab with chemoradiation was 68% and 57% when in the placebo group. The hazard ratio for disease progression was 0.7, and no new safety signals were observed, which is, I think, fantastic, especially given the 0.7 hazard ratio that we're seeing. PFS.
Yeah, absolutely. I mean, these patients with the locally advanced cervical cancer often are quite symptomatic. And the prospect of adding chemo, radiation, and now immunotherapy on top of that, it's really encouraging to see that it was such a well-tolerated regimen. I believe that there were patient-reported outcomes recently reported at SGO.
Absolutely. So the safety profile of the pembrolizumab and chemoradiation was consistent with the known profile of the individual treatment components, and no new safety signals emerged in the pembrolizumab chemoradiation arm. So you're right, it was very well tolerated.
What would you say are the takeaways for folks who are seeing these patients in the community, these locally advanced cervical cancer patients? They're adding immunotherapy in a space that we've not used it at least routinely in the past in terms of combining it with chemoradiation and gynecologic cancer. What are some of the things they should be looking out for?
Well, I mean, I think that with the hazard ratio of 0.7 and the patient-reported outcomes showing no new signal, I think we can say that there is a positive benefit to risk profile of adding pembrolizumab in combination with chemoradiation, and that we should feel comfortable using this regimen. Now, of course, we have to individualize care and be able to know when to use bevacizumab, when to use immunotherapy. So taking the whole patient into consideration becomes important. But for those individuals who are able to receive, these drugs, who don't have any contraindication to receiving these drugs, I want to incorporate them since the safety profile has been demonstrated.
I would add to that, Dr. Ferriss, that right now we only have FDA approval in the US for stage 3 to 4A disease, and that's 2014 staging. Mind you, we are now in 2018, so you have to be very careful and follow the correct FIGO staging. But the FDA only gave approval for stage 3 to 4A disease, even though the study included patients with earlier stage disease and positive nodes.
That's a great point. Thank you. So, Dr. Duska, thinking about endometrial cancer and advanced endometrial cancer, we've seen a similar revolution in the care of patients over the past few years with major shifts in our approach. Can you remind us how we got here?
Yes, but only because I'm old and I've been around for a long time. So I would say in the 90s and before, but maybe even the early 2000s, we used a lot of radiation for endometrial cancer as adjuvant therapy following surgery. And the general consensus and what we were all taught was that this was a chemotherapy-resistant disease. And then we learned from a variety of GOG at the time, gynecology oncology group trials, that this disease is actually chemosensitive. And we went through a series of chemotherapy drugs ranging from adriamycin, cisplatin, to Taxol, adriamycin, cisplatin, and finally to Taxol and carboplatin, demonstrating that this disease is actually quite chemosensitive. With this realization came the idea that maybe it would be important to combine chemotherapy and radiation, particularly in the high-risk endometrial cancer cases. So those, for example, with positive nodes or patients with high-risk histologies such as clear cell or serous cancers. And so two very important trials were done. One of them was PORTEC-3 and the other was GOG 258, which looked at combining chemo and radiation together to see if we could do better than one or the other alone. And they're very different trials, and they looked at different populations of patients, and they looked at different things. So, for example, PORTEC-3 randomized patients to receive chemotherapy and radiation versus radiation alone, whereas 258 looked at chemotherapy and radiation versus chemotherapy alone. And without going into a great amount of detail, I think what we learned from both of those studies, and I think surprised many of us, that the arms that included chemotherapy, those patients did better. And in fact, the results of GOG 258 can be interpreted, and this is somewhat controversial, but can be interpreted that many of these high-risk patients don't need radiation at all, or perhaps need tumor-directed radiation. So, for example, chemotherapy followed by tumor-directed radiation, either to the vaginal cuff, because the vaginal cuff is at risk for recurrence, or perhaps to an area of concern, maybe the cervix, if there were cervical involvement, or if there's a particular concern for local recurrence in a particular patient. So I think the pendulum has swung from almost always using radiation alone to, in more modern days, using chemotherapy and using radiation much more sparingly. And then comes immunotherapy.
So update us on the results of NRG, GY018, and Ruby.
So we've already talked about the keynote basket trials, which really contributed a lot to our understanding of the importance of MMR deficiency and microsatellite unstable disease. So the keynote 158 study and the Garnett study showed us how important it was for women with MMR, D, and MSI endometrial cancer to receive checkpoint inhibition, and actually with remarkable response rates to women who had already been pre-treated. But we also learned from the Garnett trial, which included MMRP patients, that the response rates in MMRP were not that great. And that led to Keynote 775, which looked to combine pembrolizumab with a VEGF inhibitor, lenvatinib, to see if we could make the cold tumor hot. And indeed, we could. And not only could we improve the response rate in patients with MMRP tumors, but we could also improve the response rate in patients with MMRD tumors. They did better with the combination than they did with pembro alone. That led to the idea of combining checkpoint inhibitors with chemo upfront. The idea there was we were going to take paclitaxel and carboplatin, which were our backbone for advanced or recurrent endometrial cancer, and add immunotherapy to that. And to your point, GY018 and the Ruby trials did just that. And they allowed MMRD and MMRP patients and combined paclitaxel and carboplatin, either with dostarlimab in the case of Ruby or pembrolizumab in the case of GY018. And these studies, both of which were reported and published in the New England Journal last year, showed remarkable findings in the upfront setting and potentially in the curable setting. And the OS data for Ruby were presented at SGO this year and were remarkable for MMRD patients. In the whole population, in the whole group in Ruby, there was a 16.4-month improvement in overall survival with the addition of dostarlimab, which is just huge. When you look in the MMRD group, I think Dr. Powell described the overall survival improvement as unprecedented. I believe that was the word that he used. Also, he called it very robust, with a hazard ratio of 0.32 for the group that got dostarlimab and a median OS that was not reached. So really remarkable. In addition, in the MMRP group, there was a 7-month improvement in OS that was significant. So that's really amazing in the Ruby trial. It's also of note that the Ruby trial allowed carcinosarcomas, whereas the GY018 study did not. So I think it's fair to say that these results apply to carcinosarcs. It's also really important to note that many of the patients in the immunotherapy group who received placebo, 41% of them got IO in a later treatment line, and these OS data still stand. So that's really interesting and hypothesis generating. For GY018, we don't have mature OS data yet, so we can't talk about OS, but we saw a similar improvement in PFS in both arms, in the D and the pMMR, with an OS trend in both arms that was also reported at SGO. GY018 was a little bit different, though, because they unblinded at the time of the PFS reporting last year. And so those patients were unblinded a lot earlier than the Ruby patients were. So interpret the data in that vein. The OS data not mature, but we anticipate, looking at the PFS curves and the preliminary OS curves, that the OS data will also be statistically significantly improved for pembrolizumab in GY018. What's also really interesting, and we haven't talked about molecular subtypes, when we look at the molecular subtypes in Ruby, and I'm sure we're going to see data on the molecular subtypes in GY018 coming up, different molecular subtypes of endometrial cancer respond differently to IO. And so there's going to be lots of really interesting data coming our way soon that we're really excited to see that will help us triage patients appropriately into treatment regimen.
Dr. Lea, did you have a thought?
Yeah, I just wanted to comment that, looking at the DMMR survival curve in the Ruby trial that was presented recently, and one thing that really strikes me is the importance of adding the IO at the time of initial treatment. The separation of the curves persists. And like you just mentioned, Dr. Duska, I mean, some of those patients who received placebo then later on went to get an IO treatment, but at the same time, you still see a vast separation of those curves. So I think it's really important to note that immunotherapy should be used upfront, especially in these DMR.
Yeah, I completely agree with that. And I think that might be, I mean, this is just a hypothesis, but I think that might be why we saw a difference with the addition of immunotherapy in the MMRP group, because it's possible that the chemotherapy created an immune environment that made the checkpoint inhibitor work more successfully than it would have otherwise. So really good point. You definitely need to include the dostarlimab or pembrolizumab with the chemotherapy and then as maintenance therapy after.
So you mentioned, we're increasingly thinking about endometrial cancer in smaller and smaller buckets of patients with very prescribed molecular profiles. We don't yet have enough information to specifically tailor treatment. How are you approaching that today in patients that you see in clinic?
Well, the MMR, and I'm interested in what you both are doing also. It's easy with the MMRD, MSI high patients. Those patients all should receive a checkpoint inhibitor, no question. The patients that are P53 mute, I test them for HER2 because we do have data to suggest that trastuzumab or TDXD might be useful in those individuals, HER2 positive. And then the remaining patients, also called the NSMPs, that's a difficult group. I'm interested to know how you all manage them. I think that's the group where more clinical research is really needed to determine what the best treatment regimen for them is. But I'm interested in both of your thoughts on that.
Dr. Lea?
I would have to say that I do exactly like you do, Dr. Duska.
And I would say our approach is very similar. And we have a robust discussion always about the use of immunotherapy with chemotherapy in the patients who are proficient MMR. But I think that most of us believe that the PFS data is certainly compelling. And now the OS data from Ruby, very compelling in both groups. And so we are routinely recommending the use of immunotherapy along with chemotherapy in these advanced patients.
I've heard the argument made that GY018 required measurable disease and so does not necessarily apply to patients without measurable disease. I'm not sure that I agree with that. I think there were clinical trial reasons why that was a requirement rather than biologic reasons. In addition, as we already discussed, Ruby included carcinosarcomas and GY018 did not. I don't think there's a reason to only use dostarlimab for carcinosarcomas. But that said, I don't know that pembrolizumab has an indication for carcinosarcomas. So devil's in the details. Don't get too lost in the weeds. I think the take-home message here is that it's really important to use IO, particularly for the MMRD patients with endometrial cancer up front. And based on the OS that we saw in both Ruby and preliminarily in GY018, we may be curing some people with this regimen. And I think we should focus on that. The overall survival for advanced endometrial cancer is not great. And if we can improve that and potentially cure some people, that's a huge advance for our patients.
Do you envision a day that we might even ask the question, do we need to do surgery?
So the rectal data would support that assertion. I'm not sure that endometrial cancer and rectal cancer are the same thing. And I think that taking out a postmenopausal woman's uterus is a lot less morbid than potentially radiating or taking out somebody's rectum. I think a different question would be, is there a day when we would stop doing node dissection? And we could definitely debate that. But I don't see that happening. Do you see that happening anytime soon? A stopping of hysterectomy for endometrial cancer?
I don't see that happening anytime soon. And I think, like you said, taking out, the uterus, tubes, and ovaries, it does provide us some information about whether you're even dealing with a secondary primary, but also it's from a quality of life standpoint. I mean, if a woman has a large uterus that's uncomfortable, postmenopausal bleeding, avoiding bleeding during the course of treatment. So many reasons why I wouldn't be too much of a hurry to want to not do surgery for these patients.
So we'll put a plug in for our fellow gynecologic oncologists that we still have a role to play in the incorporation of the treatment regimens for patients with advanced uterine cancer. So it's not just medicine, right? There's still a role for surgery.
I think that's very fair. Yeah.
Okay, I think that's the time we have for today. I want to thank our listeners for their time. And you'll find the links to all the studies we've discussed today in the transcript of this episode. And finally, if you value the insights that you hear on the ASCO Daily News podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts. Thank you.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.